Okay, thanks very much. Thanks. It's a great honor to be invited again. So I hope, this is a huge topic. I've tackled it, in terms, it's called Understanding Emotion Regulation. I want us to understand the background behind what goes on with clients and patients that we meet who are having these kinds of difficulties, and a little bit about kind of what we can do to help them, what we can do, to help ourselves when working with patients like these. And there'll be time at the end for questions and everything, but there's a small group, so feel free to ask me throughout. Okay, as Adriana said, I'm an outpatient psychiatrist at St. Mike's. I work in the Emerge and at Sherburne, and recently in the urgent care program, we've started a DBT skills group that I'm co-leading. So it's certainly gotten me more exposure to this particular topic. So basically what we're going to go through today are what are emotions, and just note for this talk, I'm going to use the word emotions and affect interchangeably. Affect is a clinical term we use. It's in the DSM. There's not a great difference between emotion and affect, so don't take them as anything different. What is the regulation of emotions, and what is dysregulation? I'm going to talk about clinical manifestations, what we might see in patients, and what can we do to treat, a little bit about that. So I'm just going to start with what are emotions. I included this picture. I don't know if any of you guys have seen this movie, Inside Out. It's a great movie. If you haven't seen it, it's really wonderful. And they did a really good job, I thought, of talking about the different, this doesn't include one of the core emotions, but it includes 5 out of 6 of them. And I thought it did a really great job of explaining how everybody has these different emotions and how they can kind of react together. So I thought it's something to think about, how different emotions can kind of take control of us. So what are emotions? So they're meant to be kind of distinct and brief. That's different than mood, right? A mood is a longer lasting state, and it can include multiple different emotions, different intensities of emotions, conflicting emotions. The emotion or the affect itself is kind of more of the short-term acute feeling. So I'm going to be talking a lot about negative affect. That's going to be the majority of what I focus on. So negative affect or negative emotion, sometimes I abbreviate it on the slides as NA, is the disposition to experience what we call aversive affective state. Yeah, it's great. So states of emotion that we are not comfortable with, that are hard to tolerate, and for some people with disorder, with different personality or other disorders, they're thought to be impossible to tolerate. So some of the examples of the negative feelings that we all experience can be anger, fear, anxiety, shame, and disgust. Some of us can tolerate those reasonably well. Some of us are extremely sensitive and get very hurt by experiencing those. Emotions evoke in our bodies and in our brains a certain set of behavioral experience and physiologic response patterns. And I'm going to go into a lot more detail about what those are so we can really understand it starting from the physical point of view. So emotions come up usually when there's something important to us. I mean, it could be something that might not be important to somebody else, but it signals something worth attending to for us, right? It takes our focus into that. Could be triggered really automatically, like seeing a snake and recoiling fearfully. Although last year I went on a hike in Texas and I was excited to see a snake until my friend who was Texan was like, "That's a rattlesnake." And then I recoiled fearfully. Or it might arise only after we really think something through, right? So a lot of us have had that experience of having a conversation with someone or seeing something, and it provokes a lot of thought in us, and then we come up with a reaction. So it can be anywhere from very fast to very slow. So there's thought of it in research around this to be 6 basic emotions that are kind of felt with by all, anyone kind of from toddler to elderly, any culture that you're from, any gender that you are. These are basic emotions that seem to be really kind of, built into all humans. And those are anger, disgust, fear, happiness, sadness, and surprise. Again, they can combine and have different intensities, but probably a lot of what we're thinking of with the clients that we work with, emotions that are hard to tolerate, are usually things like anger, fear, and sadness. Those are the ones we probably hear a lot about. So I included this wheel, which I think is an interesting one. It includes in the center those basic emotions, and then words that sort of describe them very specifically. So this is sometimes they may use this in CBT, or if you're teaching your clients kind of how to better identify their emotions, how to really specifically know what's going on. You can just look up emotion wheel online and you'll see things about this. But anyway, so all the emotions that we feel can usually kind of come down to one of the basic ones. So I'm going to talk now about sort of physically how we experience the emotions, the affects, what happens. So basically our physical responses are controlled by activities in the nervous system. There's three kind of systems that are really important here. There's the and I'll explain them, the sympathetic, parasympathetic, and enteric. So enteric basically means your GI tract, which, as we all know, if you think about people who are anxious and get symptoms of IBS, for example, our stomach, our digestive system is very important in emotions. These systems control the non-voluntary muscles in our body, right? The voluntary muscles are those we can choose to move however we want, but muscles mediate how our organs move and how our glands work. So the sympathetic system is the one that prepares your body to use its metabolic storage, to use its energy in a situation of threat. And when you hear the word fight or flight, that means sympathetic system. It has nothing to do with being sympathetic as a person. I don't know how those terms are connected, but basically that's just the name of this nervous system. We also have opposing that at all times, and they can be in balance at different times, or one stronger than the other, a parasympathetic division, and that kind of includes the enteric, the GI tract. It's the opposite. When there's no threat, when it's thought to be a situation of safety, your body has just worked on building up those reserves of energy and sort of keeping itself going. And we can think of that as the rest and digest, right? So here's just an example of some of the symptoms in some of the organs in the body that are controlled by this. And an easy thing to look at is just the eyes, right? When the sympathetic nervous system is activated, when it's a situation of threat, your pupil dilates. You need to see everything around you. When you're relaxed and your parasympathetic system is on board, you don't need to look all around. You don't need to be that aware of your surroundings, so your pupils contract. So this can get expressed in ways that are very visible to other people, right? When people talk about anxiety, their heart beating faster. There's blood flow to skin. People blush or they get pale when they've heard bad news, right? Piloerection means hair standing on end. We might sweat. Gastrointestinal motility means you might feel like going to the bathroom, or you might seize up, right? I think, for me, I know whenever I had an exam, my stomach would really hurt. And that, was an example of this system taking over. So these are also ways that, emotions, even inadvertently, are communicated to other people and kind of can get a response going. So there's different patterns of nervous system activation that are related to different situations and different emotional states. And that can actually go both ways, right? So even if we produce certain things voluntarily, that can kind of feed back to the brain, right? There's times where, let's say your heart might be beating fast because of exercise. For some people, that can induce a panic attack because it's almost getting their body into that state of anxiety, right? This also relates to DBT. There's a technique in DBT called half smile. And basically, that's a technique for kind of dealing with if you're having trouble accepting something, if something's bringing up a lot of emotions in you, you're supposed to kind of put a half smile on your face, not like a full giant smile, but it's called turning the corners of your mouth upwards. And that's thought to bring that response back to your brain, like actually things are okay right now. And it tones down some of the other emotions. So it is a feedback loop. So there's complex stimuli mediated in the brain, right? I think we can all kind of know this intuitively because we know that even if nothing's going on around us, if we start thinking about something exciting, we might feel some of this, right? If we start thinking about something anxiety-provoking, if we think about that exam, we might feel our hearts start racing, even if nothing's happening in our environment at that moment, right? So we know that the brain itself is kind of taking over. So I'm going to talk a little bit just about how this works. I hope this is of interest to people. I just think it's good to kind of know the basics, stripping it back to really those very basic physical processes. So information is kind of relayed from the cortex. So the cortex is sort of the main part of our brain, the thinking part of our brain, to the nerves that communicate with the body via a sort of way station in the brain that's called the hypothalamus. These are some of the important structures that coordinate how we express and understand our emotions. And I'll talk a little bit more about them. So cortisol is kind of one of the messengers here, and we've probably heard about cortisol, so I wanted to explain it a little bit more to people. So cortisol is a hormone messenger in our body. It's moderated, again, this is not, you don't need to really know the details, but the hippocampus, if you've heard of it, is a part of the brain that has to deal with memory, for example. And it has these receptors called glucocorticoid receptors that kind of get cortisol and read that as a message. People who've gone through childhood abuse, which is basically a state of uncontrollable stress while their brain is developing, actually grow less of these receptors. And that means that there's kind of a constant uptick in cortisol because it's trying to relay this message, but there's not enough receptors to get it. So they're going to have a higher rate of cortisol. They're going to have bigger surges of it. They're going to have a higher level of it in their blood. That can actually be pretty physically toxic to other parts of the brain. The hippocampus, the one that codes those memories, and the prefrontal cortex. I'm going to talk a bit about the prefrontal cortex. Basically, that's the sort of most modern, evolved part of the brain. And we'll talk about what that does, but it's really important for emotion regulation. So the more these cortisol levels are heightened, those parts of your hardware can sort of stop working quite as well. So there is sort of a physical level where the emotional reading and understanding doesn't work out too well. And that's just a picture of the cortisol molecule. So we're going to be talking, about two parts of the brain. It's like two different brains that act together. There's the neocortex, which is sort of our thinking brain, and our limbic brain. That's sort of that's that center that relays things to the body. So these are just some parts of the prefrontal cortex that are important in different functions. The prefrontal cortex, there's a specific part of it that comes up a lot when recently they've started actually doing a lot more research on emotion dysregulation because it's such a common part of so many illnesses that it started to come to attention for people who are interested in the neurology of this. So this is a part of the brain that really has to do with impulse control and inhibiting responses. So that is saying having that impulse and being able to stop it. That part of the brain is connected with the limbic system structures. That's that relay station that goes to the body. So I put this picture here. I don't know if anybody knows who this is. It's someone called Phineas Gage. Has anyone here ever heard of them? Okay. So Phineas Gage is an interesting person from the 1800s who was thought to be a pretty calm guy. And he worked on the railroad. You can see this black and white picture. He's holding a railroad spike. That's because he became famous because I guess there was some kind of accident in his workplace. The railroad spike went through his brain and came out this part of his skull. And he survived. It didn't hit any of the important parts of his brain for breathing or anything else, but it did go through what's probably his kind of orbitofrontal cortex. His personality changed after that. Instead of being a calm guy, he became an angry, aggressive, and volatile guy. So that gave the doctors at the time the idea, like maybe there's a certain part of this brain that's impacting this. So he's kind of become a famous figure throughout, and that's a model of his skull. So the prefrontal cortex, again, this is the most evolved part of the brain. So it's important to know, kids are not very good at regulating their emotions, right? They're still growing this part of their brain. Animals are not very good at regulating their emotions. They don't necessarily have this fully developed, right? So when we talk about being evolved, what's different from humans versus animals, it's really thought to be this, the prefrontal cortex. So this is the area of our brain that controls self-organization and self-direction. It can kind of bring together your thoughts and your actions in order to achieve goals. So it's that long-term thinking part. It's called the executive functioning part of the brain. So you think of it as the executive that controls everything else, delegates tasks, makes sure everyone is working together. So it helps you learn and maintain activity patterns to achieve the things you want. And that doesn't mean long-term goals such as getting a job. It could be goals such as, picking up the soda can and drinking it, but it helps you with that. It helps control the signals to the rest of your brain, impacting your senses even, how open your senses are, how much information you're getting from your eyes, your ears, everything. It helps you execute responses, carry out the things you want to, helps you retrieve memories at the right time. So we all know if we're in a heightened state of emotions, we're not very reliable to kind of sit down and think about memories, right? We're just kind of acting on impulse. This part can be shut off. It helps us evaluate situations from an emotional point of view. So it's really important to know that the more distress we're in, the more we're activating that other part of the brain, the limbic part, the less we're using this, right? If we're using this, we're in that thoughtful, calm state. So this is the other part of the brain, the limbic part, the brain of emotion. So it includes a few structures here that, again, I'll talk about a couple of them. So when the senses perceive danger, so when we see the snake, when we hear the rattle of the snake, whatever it is, that information is sent to the amygdala for emotional processing. The amygdala's job is to send a distress signal to the hypothalamus, which is going to send the hormones to the rest of the body through the nervous system. Just, this has nothing to do with anything, but the amygdala is called that. It means almond-shaped, I think, in Latin. And a few years ago, I was working in Ethiopia, where I didn't realize until getting there, they don't have almonds. And I had brought a big bag of almonds for Costco, like as a snack. And one day I was working there at the hospital, and I had some almonds, and I shared them with the resident, and she'd never had them before. And she was like, oh, this is the thing that's like the amygdala, right? So they had learned in their neurology textbook that the amygdala is almond-shaped, but hadn't had any almonds. So anyway, I always think about that now when I think about the amygdala. So how does information get relayed to the body? So the signals can tell the adrenal gland, which is kind of down on our kidneys, to release epinephrine. So epinephrine is the same thing as adrenaline. So think of the adrenaline response, right? Heart pumping, moving fast, getting a surge of energy. Your heart rate increases, that pushes blood to the organs so that you can act, you can move, right? When your muscles fill with blood. Your pulse rate and your blood pressure increase, you feel your heart beating. You start breathing more rapidly. It opens up the airways in your lungs because your body's saying, I need oxygen, I'm gonna need to run or do something. The oxygen also goes to your brain, open up your alertness. Your sight, your hearing, and other senses become sharper, right? Your pupils get big, you look at everything around you. You start releasing glucose and fats to give energy to your muscles to move. These happen so quickly you're not aware of them, right? You haven't even decided that you've seen a snake yet before you're jumping back, right? Or you haven't brought in that part of your brain, the prefrontal cortex, that's decoding the information. This just happens without your knowledge. As the epinephrine level subsides, another part kicks in. That part, the hypothalamus and pituitary glands, start to release a hormone that tells you to release cortisol, right? We talked about cortisol before. That keeps your brain on high alert even after the initial adrenaline surge. So you can see how this is happening all the time in someone who is constantly under attack, that child who's being abused or whatever it may be. Then the cortisol levels fall. The parasympathetic takes over, right? That rest and digest system. However, if your adrenaline is surging all the time, it damages your blood vessels and your arteries, right? You know how there's that thought that people under high stress are likely to have a heart attack? That's what this means, right? They're always surging with epinephrine. Eventually, that's going to damage some of their organs. And interestingly, since cortisol is always telling you to store energy, you have to get moving and be energetic, this really actually affects people in terms of their weight and their health, right? We talk about things like lack of sleep contributing to obesity. That's how this works. The high level of cortisol, the always being under threat of attack, means that your body is just always thinking, I need to store energy even when it doesn't. So this can really affect someone physically in a lot of different ways. So now I'm going to talk a little bit about, what's regulation, what's dysregulation, now that we kind of know how your body does it. So before we start about dysregulation, we should know what regulation is, right? So emotion regulation reflects your processes that influence kind of what emotions you're likely to have, when do you have them, right? Different stimulus evokes different things in different people, right? We all go to a movie where one person's smiling and the other person has tears, right? How do you experience those things? Do you experience them as painful, as suffering, or are they just emotions that you can tolerate? How do you express those to other people? So this can involve changes in your dynamics of your emotion. That can mean all kinds of things about the speed of onset, how long it takes you to recover, how big are they, how long do they last, what do they cause you to do? So we maybe, because of the people we're working with, think of emotion regulation as being able to decrease your negative emotion, but it's a lot more than that, right? You also want to be able to maintain positive emotions. You want to be able to, not suppress your emotions. It's a lot more than just turning off negative emotions. That's probably just the thing that we think of as most acute and most urgent for the people we work with. A lot of it is conscious, right? If someone's having a conversation with you that's upsetting, you might ask them to change the topic. You've chosen to do that. You know you're bothered by it. This is your response. But a lot of it is unconscious. If you see a scary picture, you might look away without even really registering it. So we have to be aware. Some of what people are doing, they know what they're doing. Some of it, they don't even realize it's happened automatically. Emotion regulation itself, just like emotions, is not inherently good or bad, right? People end up feeling really bad about themselves when they can't regulate their emotions. But it isn't a moral thing, right? We want to take it as the approach of these are skills people can learn. Some people just don't have those skills and they can get better at it. They just need to know how and when. So, we respond to environmental demands with a balance of sort of strategies we're aware of and strategies we're not aware of. We help ourselves modify the magnitude and what type of emotional experience we're having. We use skills and strategies. Those people who can successfully regulate their emotions typically have much better physical and mental health. They have better relationships and they perform better in work and academics. So there's a lot of reasons why people want to be able to regulate their emotions, be in balance. But then there's dysregulation. So you hear a lot about emotion dysregulation. It's not a psychiatric diagnosis itself. It can be a symptom or it can lead to other symptoms. Lacking in skills leads to out of control emotions, right? Because as we know, emotions can be a cascade, right? You might get angry and then feel really ashamed of it later, right? And if you cannot work on the anger, then it's going to be really hard to work on the shame after. So it can kind of generate itself ongoingly. A lot of the symptoms, a lot of things in the DSM, a lot of our diagnoses, what we call symptoms are actually just failed attempts to regulate emotion. So we call those dysfunctional strategies. It's an effort at a strategy. The person is trying to stop a painful emotion or trying to tone it down. They just haven't picked the right way. The more you lack in positive, helpful strategies, the more you're likely to turn to dysfunctional strategies. Everybody has good strategies and bad strategies, right? And some strategies might be very functional in one setting and really a bad choice in another, right? So what I want to convey is that the bigger array we have of strategies, the better off we are, the more flexibility we have, and the more we can slow ourselves down to decide. Those are all really important skills to have. So I'll go into more detail, but from the point of view of a psychiatrist, a lot of conditions involve things like impulsivity, self-harm, and substance use. And I'll talk about how those things work, but those are really clear examples of dysregulation strategies. So again, in that situation of distress, someone who knows their emotions are out of control or too intense, they're going to experience distress in two parts. First of all, there's the painful emotions that they're trying to avoid. And then there's that feeling that they can't control their emotions. They can't seem to do anything about it. So there's a lot of extra distress built in. So emotional dysregulation can have all kinds of aspects. The person might not understand their emotions. They may not be able to accept or be aware of them. They may not know what they're feeling, right? We've all worked with those people. You see they're in distress. You ask them, what's going on? They say, I don't know. So we might call that in psychiatry alexithymia, which basically means illiteracy of emotions. That person doesn't have the language to say what their emotions are. And that's someone who might benefit a lot, for example, of learning about that physiology, learning about, oh, my heart's beating fast. That's meaningful, right? Because they can't seem to say, I'm sad. That information's not there for them. Could be difficulties engaging in goal-directed behavior, right? This happens in DBT a lot. People, when they're starting DBT, say, it's great to know these strategies, but when I'm at a 10 out of 10 emotion, I can't do it, right? So that means involving a lot of treatment to help them not get to 10 out of 10 or making the processes so automatic, so practiced that they can deploy it without thinking at 10 out of 10. So someone might know the strategies, but they may not have the wherewithal to do it when their prefrontal lobe is shut off and their hypothalamus is super active. The inability to inhibit impulsive behaviors, right? A lot of people come to you wanting to stop doing things like, using drugs, which I'll talk about, acting in terms of self-injury. They may say they don't want to do it, but they just can't seem to stop themselves. It just happens. And then there's maybe a lack of alternative strategies. Maybe somebody only has those dysfunctional strategies. That's all the effort they can put in. They just haven't learned enough positive strategies. So some of the features of how do you know an emotion's dysregulated, right? Because not all negative affect, it's normal to have negative affect. You're going to be sad sometimes, you're going to be angry sometimes, but how do you know that they're not regulated? So people who have a high sensitivity to emotions, especially in a social context. So we often talk about people being rejection sensitive, sensitive in general. We talk about them being interpersonally volatile. They're likely to have dysregulated emotions. People who show a heightened, so like more than we would expect, show of affect, labile means very sort of sensitive to change, right? These are emotions that can change really quickly from, you might say something to them that you think is reassuring and they might react really heightened to that. So that's labile. Again, that deficit, they may say, I just don't know what else I can do right now, or everything they know how to do is not really that helpful for them. Now, we're talking a lot about underregulation. I also want to make sure people understand that overregulation is also dysregulation. So underregulation is kind of letting the volume be up so loud, right? But some people, their response is to shut the volume right off. That's still dysregulation. And that can look like numbing and dissociation, which we'll talk about, but that's also dysregulation. It's not always as obvious to us as clinicians because the person's not screaming at us, so we're not as worried, right? But it's still really important. The same things are happening in their body. They may look totally like they may not be saying anything. Their cortisol level might be through the roof, right? So it's still having the same impact on their brain.
Can you give an example?
Yeah, for sure. Could I give an example of overregulation? I'm trying to think of a specific example, but I certainly have had patients that are likely to dissociate. So you might know that a person is dissociating. I think I talk about this in a couple of slides, but they kind of have a glazed over look. They seem to be kind of distant, and this can happen really quickly, right? So sometimes I've had a conversation with a patient trying to explore something that they seem really engaged in talking about, and then a couple of minutes later, it's like they're kind of a different person. They're not screaming, they're not doing anything, they're just kind of like out of it, not very attentive. They might look kind of tired, right? This might be someone, I have one psychotherapy patient who's much more on the overregulated side. I sometimes know that we're talking about something that must be really impacting because he'll yawn and he's not otherwise tired, but I know that that's his body engaging in some attempt to overregulate. Yeah. So yeah, what might this look like? The person might complain that they have dissociation and numbing. They shut down, they can't feel things. Rage, right? Rage is not the same as anger, right? Rage is like a full body out of control experience. Violent outbursts, someone might throw something. Impulsive and reckless behavior, that's going to be really individual to the person. One person might have uncontrolled, unsafe sex. One person might, drive too quickly. One person might start gambling. That's going to be individual, but behavior that's unhealthy and not thought through could look like substance use. And again, one of these overregulation strategies, it could look like avoidance, right? I know I have plenty of patients who will miss an appointment. And then when I ask them the next time I see them, well, why'd you miss it? And they said, I was having a bad day and I really couldn't face talking about it, right? So that was their strategy, was to not talk about it. So how might this look to you if you're meeting with a client or a patient? They may be threatening to self-harm or to kill themselves. They may be scaring you with their intense emotions, right? They may be inconsolably crying. Their distress level is so strong. They may be raging at you, raging at somebody else. Physical overactivity. They could be pacing around, shaking. They'll look like they're kind of physically taking over. Or they might be dissociated, right? You may not be able to talk to them at all. Or they may be unable to engage, poor eye contact, not gazing at you, kind of, I had a patient last week who needed to sit on the floor. She couldn't sit level to me. That was, I think, what was going on with her. So there's a way that emotion dysregulation can be externalized. It can be visible. So these are those heightened and excessive emotions. It could look like excitement seeking, trying to distract themselves, right, by something else intense. So again, you see this with aggression, alcohol and substance use, disordered eating, self-harm, or thinking about suicide. These are all external strategies. There's also internal strategies. These are those shutting down strategies. That can be rumination. So when we talk about ruminating thoughts, but the word ruminating comes from cows, right? So cows have 4 stomachs. They have to chew the food in different ways and then kind of throw it up into their mouths to keep processing it. That's what these thoughts basically are. They're like vomiting thoughts that just kind of keep back into your brain the same thing over and over. You can't really process. Could look like panic, could look like self-criticism, telling yourself that your emotions are not valid, that you should not be feeling a certain way. Could be social inhibition, and that can become total isolation from other people, total avoidance. And it could be something as subtle as reduced focus or attention. We all know that if we're having a bad day, if something's bothering us, we got bad news, we can't focus at work, right? But it might be like this all the time or really badly for somebody. They cannot take their mind off of it. So just, I think one way of thinking about it is that there's kind of thought of different emotion regulation strategies. One is called antecedent focus. Basically, that just means like a preparation strategy or to try to nip something in the bud. Before the emotional response becomes too high, you try to work on, like calming it down. So, obviously we would probably think about this as good preparation. These strategies are probably pretty useful to try to reduce, things from being at their worst. And then there's response-focused strategy. So after something has already happened, how do you deal with it? So some more specific forms of these strategies, a big one is reappraisal. So that's sort of reevaluating your perspective in a situation to try to reduce distress. Anyone who's familiar with CBT, this is basically all that CBT is, right? It's kind of trying to say like, okay, I'm feeling a certain emotion. What's another way I can think about this? Is there a way that I can reevaluate this to change my thought? So, this actually seems to, when they study people who are actually in the process of reappraisal, their prefrontal cortex lights up and their amygdala calms down, right? So that means that their tone, just going through the process of trying to think of something, a different way to understand something, engages your executive functioning, allows you to be more in the decision-making phase, and it helps your body control itself. And that's an example of an antecedent focus strategy. There's mindfulness, which is learning to accept our emotions without changing them, but without judging them. And there's rumination, right? Rumination is a dysregulated strategy because it's sort of our attempt to try to think of something, but it's not processing it. It's just, again, kind of like vomiting it back to yourself, so you can't really solve it as a problem. Then there's suppression. Now, we think of suppression usually as a bad thing. It's the intentional attempt to minimize the display of emotion, but we all do it, right? You might be in a meeting at work, something's really pissed you off, you want to scream at somebody, but you're not going to do that, right? Unless you're very dysregulated. Okay, maybe I can, make a comment and ask, say that I don't agree with this, but you're not going to scream out loud even if you feel like it, right? And that allows your prefrontal cortex to activate. That's a response-focused strategy. After you feel that anger, you say, oh, I'm not going to scream right now. I'm just going to talk and ask a question. But suppression, you can over-suppress too. So how do people develop dysregulation? Why can some of us handle our emotions really well? I mean, negative emotions are hard for everybody. But how come some of us don't end up, attempting suicide over it and some of us do? So one important thing is temperament. So I picked this picture because it shows that people have known about temperament even from like ancient times. This was something that was discussed in like ancient Greek times. And we still use some of these words. One of the temperaments was called melancholic. So we still talk about people being melancholy, being depressed. So it was thought that everybody was born with a different system of their body. They thought it was related to organs in the body. That's not necessarily supported by our modern scientific thought, but they already kind of knew the connection between body and mind. That, people who are born melancholic, those are the people who are going to end up being more sad in situations. And people who are born, one is called sanguine, are more relaxed. So it was known that people are kind of born with different tendencies. So basically the temperament is something it's mostly genetic. It's kind of there when you're a baby. There are other things that can kind of influence it over time, but, this is sort of like a physical thing. Everyone has a core of individual differences in style, and this is basically ways of approaching and responding to the environment. That's stable across time and situations. Your temperament when you're an infant is still going to be pretty much your temperament when you're an adult. That doesn't mean that everyone with a temperament ends up a certain way. You develop a personality as you get older, as your brain develops, as situations influence you. But someone who, anyone who has children or has interacted with infants knows that there's different ways that this can look. So some infants are called easy babies. So this is probably 30 to 50% of babies are thought to be calm, even-tempered, and cheerful. These are the kids that, are easier to get them to sleep and to feed them. They're not so fussy, right? Doesn't mean everyone who's like that is going to end up being a happy person when they grow up. They may not, but they just may have an easier time biologically. Then there's other babies that are the difficult babies. Again, it doesn't mean they're going to have emotional or mental health problems later on, but there may be difficulties that they end up having. They have more intense and longer stress reactions. They're easily provoked by things that, they'll start to cry very easily, and it's harder to get them to calm down. But that doesn't mean that having that reactive temperament is dysfunctional or going to cause you to have dysfunction, because that's 30% of kids. That's a lot of babies are that way. Basically, what ends up happening in an unsupportive environment, a reactive temperament child will show decreases in functioning. However, that same child in a supportive environment will actually do really well, maybe even better than the easy child. And that's probably because their reactivity can be a positive thing. It can help them be curious about the environment, it can help them be really engaged with other people. But you have to kind of give them the right environment to make it a positive. So the really important factor here is trauma. So, I think we're all aware of being trauma sensitive, but it's really, really important for emotion regulation. Trauma is any experience of kind of catastrophic affect. Usually it's related to fear, that the individual cannot process or understand or integrate into their life experience. It's something that overwhelms you. It's such an intensity of feeling that as it's happening, your brain kind of might freeze or shut down that prefrontal area. Now, that might be a survival tactic, right? If you experience every emotion while, let's say, you're being abused as a child, that you may not get through the situation. If you shut your brain down, you might survive, right? So it is actually a strategy that works in one situation. The problem is when you keep having to engage it. That can leave large gaps in memory. We all know, patients or clients we worked with who know that something abusive happened to them, but they cannot remember it, right? Their brain was not with them as it was happening. Eventually, that can lead to ruptures in the sense of self, right? If things happen to you, things that are very difficult to understand, that you couldn't really ever process, you're not really going to know who you are. Especially if someone's growing up, they're being abused by a caregiver, it's too overwhelming to think this person that, gives me food and cares for me and is responsible for everything in my life, responsible for all the good things in my life, also wants to hurt me. That's so hard, especially for a child to understand. It's really hard for them to eventually understand who they are. So the more this happens, it can lead to what we call in psychotherapy rigid defenses, which is basically kind of inflexible strategies is how this ends up looking, right? They just kind of have one way of reacting over time, and it's not really very adaptive to other scenarios. So I'm going to talk a lot about this. There's a huge correlation between trauma exposure and emotional dysregulation. I mean, I'm going to reiterate this a lot of ways, but the more trauma someone was exposed to as a young person, the more likely they are to have more severe emotional dysregulation. So attachment. This is like just one slide. Attachment's a huge area of study, but basically having a secure attachment with a caregiver in early life, especially as an infant, as a toddler, is really thought to be the essential building block of any emotional regulation. Part of that is role modeling, seeing someone who can do things and kind of learning from them. But it can be as simple as a mother who had postpartum depression. She may be able to care for her child in terms of feeding and clothing, but she cannot emotionally respond to him because her depression is too great to be interactive. That child doesn't really get to see different responses, right? They only see a shutting down, and that's what they learn. And kids have a lot of emotions. Babies are upset all the time. They need somebody to help them understand, oh, this is what that means, and maybe eventually they learn to take care of it. So children who experience maltreatment couldn't really take in the idea of their caregivers very well. Like, they couldn't describe their parents too well. They had a disorganized idea about them. That led to childhood emotional dysregulation. It led to kids who were more aggressive and kids who couldn't really interact well with peers. Interestingly, 80% of kids who were maltreated seem to have problems with emotional regulation, compared to 37% of non-maltreated controls. Still, 37% of non-maltreated kids have emotional dysregulation. Basically, all that means is they're kids, right? Their brain is still growing. They haven't learned those strategies yet. It's not only maltreatment that causes it. Some of it is just immaturity, some of it is their temperament. Oh, sorry. Oh no, I went back to the beginning. So it is very common. That's why we don't expect children to be mature the way we expect adults to be. Hold on, let me move back to where we were. Okay. So I put this picture here, if anyone's familiar. This is Harry Potter being attacked by a Dementor. So I thought that was an example of childhood trauma. So basically, being maltreated as a child, you can't acquire those skills. No one's teaching you the skills, or people are teaching you the wrong skills, right? If your parents are teaching you that when you're angry at someone, you have to scream at them and hit them, that's what you learn. You don't learn, okay, you talk to the person and you or you take a break or whatever. Repeat trauma, you're being taught this time after time, right? If something traumatic happens to a child once, that may not have that same negative effect, but usually if you have someone in your life who's abusive or neglectful to you, it's happening all the time. It has effects on the way that your brain forms, and it doesn't allow you to grow interpersonal communication or to be able to interpret cues from other people. So you can see that that's going to end up causing problems with your peers. You're not going to be able to make friends. You're not going to have those positive experiences to teach you something else. So it really impairs a lot of different aspects in your life. So, for example, kids who experience sexual abuse are shown to be less able to understand their emotions and regulate them. They actually expected not to receive emotional support, and they started to get the idea that if they express negative emotion, which it's normal for kids to have negative emotions at times, that they thought they'd encounter conflict. That's their expectation. So they were fearful of showing sadness to their parents or anger to their peers because they anticipated a negative response. Kids who experience neglect, I think neglect's a really important thing because, we have ways of asking people about abuse, but neglect's kind of more subtle. It's really, it can be even more deleterious to a person's development than abuse because they really don't know how to expect anyone to take care of them. They don't learn how to take care of themselves, but it's a little bit harder to kind of ask about. So it's important to keep, to listen if you hear a client's stories of not having had enough to eat or not having had any adults around the house, things like that. Those are signals of neglect. Kids who experience neglect didn't understand their negative emotions, right? Because no one was explaining it to them, that this is how you feel and this is why. And they didn't have any skills to regulate them. Nobody had shown them. So they're likely actually to suppress. When those kids are likely to be afraid to show their emotions to parents or teachers because they're anticipating not getting any help about it. They don't expect to get support. So even preschool kids, even kids that young in age, are not as good as their peers at seeing different emotions or identifying their own. And actually, kids who were physically abused are too good at identifying anger because they've been primed to be fearful of a parent or caregiver's anger, right? So they could see anger really early, but that kind of leads later in life, you might overinterpret other people's expressions, right? In people with borderline personality disorder, it's said that when they encounter a neutral facial expression, they interpret it as negative. So they're more likely to always think that people are angry with them or disappointed with them, and they react accordingly. So they couldn't really, and they actually were over-attentive to those facial cues. So if they saw someone being angry, they got over-attentive to it, right? They got too nervous about it. So, basically emotional dysregulation and the severity of your childhood trauma, how much negative affect you experience, those are all correlated. It could lead to PTSD, drug abuse, depression, suicidal ideation. And interestingly, people can have PTSD for all kinds of reasons, right? But if it's a non-interpersonal trauma, if it's not something that had anything to do with anyone in your life, right? Like if it's a natural disaster or something else, you still might get PTSD, but you're probably not going to have emotion dysregulation. It'll look different ways. So it's there's a very specific link between that childhood trauma and dysregulation. So people who had PTSD, their emotion dysregulation basically kind of looked like difficulty accepting and recognizing their own emotions, difficulty using strategies, and being more impulsive. So again, the most powerful predictor is emotional abuse. That means you didn't learn skills from other people. You didn't learn that your own emotions are acceptable to have, that they're not a problem, right? So always think about that with, clients who have had a difficult history. So yeah, this is just in summary. These emotion regulation deficits determine from both your biology, right, who you are temperamentally, if you are that more reactive person, and the intrusions from your environment, particularly caregivers, right? So again, there's some people who might be born with a certain temperament. They can withstand more than somebody else. There's a really strong association between the more adverse childhood experiences someone has had, the more mental health problems they're going to have, and the link there might be that they can't regulate their emotions, so they develop all these illnesses. So basically, the consequences. So, people kind of deploy dysfunctional strategies because they're trying to immediately reduce their negative emotions. They can't think of the long-term consequences. Their executive functioning is shut off. They can't say, having this drink now is going to, cause me to have problems with my relationship in 10 years, right? They just think of now. So, there's a lot of different ways. These are just a few examples. We know people who are anxious become avoidant and they withdraw. Some people who are lonely respond by drinking. Some people who are bored respond by overeating. Now, if you do this once, it's not going to be a problem, right? If you have lots of other strategies and this is something that happens once in a while, it's not going to develop into a huge pattern. However, if this is your only or one of your few strategies, you will repeat it so much that it will become a disorder, right? That person who's bored will end up having a binge eating disorder if they lack other ways to deal with it. So some of the diagnoses that we see related to emotion dysregulation, sort of the big poster child for this is borderline personality disorder or complex PTSD. That's our immediate association with emotion dysregulation, but it can be a lot of different things. It can be an eating disorder, can be an anxiety disorder, can be an addiction, or it can be somatizing. So somatizing is having physical expressions of emotional pain, right? So those are those people who may have that alexithymia. They may not have the vocabulary for their emotions, so their body translated into physical symptoms that are hard to treat. So aggression, so I'm just going to kind of talk more about some of the manifestations. So there's impulsive aggression. So that's emotionally charged. It's usually reactive to a personal situation and it's uncontrolled. So that's different than premeditated aggression, right? People who kind of plan out aggression, who are more sort of on the sociopathic side, that's not necessarily, they may have affect dysregulation, but that's not what that is. One thing we see often is non-suicidal self-injury. So we may also call that self-harm. You can call it parasuicidal behavior. So this is harming your body without suicidal intent. Doesn't mean the person's not having any suicidal thoughts, but they're not doing this thinking that it's going to kill them. They're doing it for another reason. Commonly, we see cutting, burning, or severe scratching, pulling out hair, things like that. The person is thinking, I'm going to immediately reduce my feelings right now. This is much more prevalent. I mean, it happens in adults too, but we see it a lot more in adolescents, and I think that's also related to the fact that their brain development is just not as far along. Sometimes it's related to interpersonal positive reinforcement, using this as a way to communicate to somebody else that you're in distress if you're not good at doing that verbally. But sort of one of the biggest factors is trying to alleviate negative emotions, right? People typically will say, if you ask them why they've done it, they're trying to relieve anxiety, guilt, loneliness, self-hate, things that they didn't have another way to turn off or to change. And the physical experience that they're having changes their mind's focus. Some people, I definitely have patients, if they ask why, they said, well, I was trying to stop my numbness. So those are the overregulated types. They're dissociating. They don't have a connection between what's going on in their mind and their body, and cutting gives them that, right? Again, not a good strategy, but a strategy. And you can kind of use that, right? If someone needs more of a physical connection between their emotions and their brain, there's ways to generate that aren't harmful. So suicide risk. So someone who's more emotionally dysregulated could be at high risk for suicide, right? Not everyone who's emotionally dysregulated has suicidal thoughts, and then they may not be at higher risk. But first of all, people may self-harm without suicidal intent, and it may end up hurting them to the point that they die. Or they just might be so impulsive in wanting to escape what they're feeling that they say, I'd actually rather be dead in that moment, and they end up killing themselves, even if they weren't necessarily feeling too suicidal, 5 hours ago. So borderline personality disorder, just a review, the affect state, sort of one of the cardinals of borderline personality disorder is having dysregulated affects, out of control emotions. People may say they have emotional roller coasters. mood swings. There's a lot of different ways to talk about it. But these are kind of emotions that change like hour by hour, and even small stimuluses like, someone not answering a text or something else that might generate an emotion in somebody else. They may not like it, but that can be enough to totally overwhelm them. So it's characterized, these emotions, by instability, rapid mood swings in a short period, heightened reactivity to the environment. Again, not getting that text response, instead of just being like, oh, that's too bad, it's like, oh my God. A slow recovery. So even when this person tries to recover their emotions, it takes a long time. And vulnerability to negative affect. Again, even in the wake of neutral stimulus, they're likely to interpret it as something's wrong. So, they're going to be experiencing negative emotions even when we wouldn't expect them to. So I don't know if people here have heard about Marsha Linehan. She's sort of the inventor of DBT, and she herself suffered from borderline personality disorder as a young person, and then kind of became the major person to work on treating it. So she, has a way of thinking about a borderline personality that's in line with all of this. She calls it the biosocial theory. Basically, she thinks that people with borderline personality disorder are always trying to have emotional avoidance. They always want to get rid of the emotions that they have. These are people who are emotionally sensitive from birth. So again, that temperament. They're likely to experience negative affect in all kinds of contexts, and they're not very good at learning those strategies as a result. They then are more likely to contribute to enact dysregulated behaviors to try to get rid of those emotions, but those dysregulated behaviors then lead to more problems. So it's a feedback cycle. All having to do with wanting to avoid the emotions in the first place. So it's thought these are people who are scared of the intensity of their emotions. So even anxiety disorder can have to do with emotional dysregulation. People with generalized anxiety disorder have a high level of intensity of anxiety. They react really quickly. They can't really regulate their emotions, right? So they'll kind of either just sit there nervously or pace or not be able to get rid of their thought, and they'll have insomnia. Again, these are people who are more likely to have other kinds of emotion dysregulation too. They're not, because they're so unregulated, because they're so anxious, they can't really deal with their other emotions, right? So let's say they start to feel hopeless because of all of this, they're not very good at dealing with that. So it can kind of catch on to other emotions. And again, this next part has to do with sort of CBT. Anyone who's done CBT for anxiety, it's all about not avoiding things. It's all about exposing yourself to things you're scared of. Because if you're anxious, you try to get rid of that anxiety by avoiding the things that make you anxious. And maybe that's as small as leaving the house. So you stop leaving the house, right? And then you get more and more scared of leaving the house, knowing that it's going to cause you intense emotions. It also prevents you from doing things that would make you feel good. So you're not able to regulate the positive affect. You're not able to go out there and have friendships and do the things that would make you feel better. So it's totally unbalanced. So I put a picture here from TV. If you guys have seen the show Mad Men, this is a character who had childhood trauma and turns to alcohol to regulate. So basically, there's a high rate of substance use disorders in people with affect regulation. I'm going to try to go through this quickly because there's a lot there, but basically, most people who use drugs and alcohol in an unhealthy pattern are trying to regulate their emotions. These may be people who are very sensitive to negative stimuli. So the more people like this are exposed to a negative affect, the higher they're going to rate their craving. And there's also a link, right? Because once you become physically dependent, you're going to try to avoid withdrawal because that comes with negative affect. So I put this picture here, hair of the dog. That's someone who tries to drink to get rid of a hangover, to get rid of the alcohol withdrawal, and then that becomes its own cycle of avoiding negative emotions. In particular, people who overuse alcohol are likely to be more sensitive to the stress-reducing effects of alcohol intoxication. Someone else who doesn't have an alcohol problem might have a drink and notice it reduces their stress a little bit. Someone who's an alcoholic is likely to be the person who thinks it reduces their stress quite a lot. So people with a family history of alcohol or drugs are likely to be very reactive and will have a higher motivation to use, right? Somebody else might think like of one strategy, like, oh, maybe I would have a drink and that would calm me down, but they're not necessarily that motivated to do it. They have other things they could do. This is someone that they really tend towards that idea. And these are people who are likely to find the idea of intoxication more appealing, that's probably because it puts you in a different emotional state, right? Someone else might say, well, I can have a drink, but I don't like to be drunk. But this is someone who wants to be in a different state. These are people who often feel negative urgency, so that's like a strongly impulsive emotion. They need to engage in a risky behavior right in response to stress. It can be a kind of automatic coping response. Again, eventually this stuff gets coded into the reward center of the brain, and it happens really without the person knowing. Now I also have a lot of patients who tell me in particular with marijuana that they're using it to self-medicate. But we don't actually know if it actually is a self-medication other than relieving withdrawal. Because substances affect people differently and in different states. There's not really a very reliable way to predict that. It might actually be more that using the substances kind of turns down their arousal in general, makes them more tired, so kind of less vulnerable to those states. It might make, turn down their attention, so they're not focused on it that much. It might be a social opportunity, right? Maybe when someone goes out to get drugs, they're doing it with other people, so that's a distraction for them. So these are, so the thought of it self-medicating, it might actually be something else related to what the substance does that seems to be changing them. However, it's really a big motivator for people with substance use disorder is the expectation. People who expect it to change their affect are more likely to go after that. So you can kind of work on that by teaching them about this, right? Kind of understanding that maybe it's not going to relieve their distress, or maybe there's other things about it like turning off their attention, and maybe there's other ways to get them. So eating disorders. So this is kind of a look into the mind with someone with eating disorders. They'll feel really badly about themselves if they're not happy with their weight. So anorexia nervosa and bulimia nervosa are really characterized by elevated negative emotions. So that term I used, alexithymia, even though we use it now, not being able to read your emotions in all kinds of settings, it was invented for people with anorexia. Those were thought to be kind of the original disorder of people who cannot read their emotions. These are people who are very sensitive to negative emotions and feel very poor at regulating their emotions. Binge eating disorder is a newer disorder in the DSM, but it's really related to affect dysregulation. People will binge in response to feeling bad. It's a negative cycle. They're not happy with their weight. Keeps going on. People with borderline personality disorder are people who are also more likely to have an eating disorder, and vice versa. So they're often related. So again, these are people with a lack of adaptive emotional skills. It's thought that they're trying to do these eating disorder behaviors to change their states. Bulimia nervosa involves dysregulated behaviors. Again, these are probably the more external emotion types. They binge, they purge, they're really heightened emotions. Anorexia are the overregulated types. These are perfectionistic people typically, the ones who typically drive themselves very strongly. I mean, these are also, usually these things develop in children. So remember, they don't have a lot of other strategies yet. Eating is one of the few things that children can control, right? So they'll develop this strategy early on. These are typically, the kids who want to be perfect, drive them hard in school and athletics. They regulate too much and they end up regulating what they eat. Again, they sort of have an abnormal response around food and eating, more heightened than other people. They're usually very sensitive to the idea of punishment and harm and wanting to avoid that. And typically, an eating disorder behavior is a response to a negative affect state. Someone will feel rejected, they'll feel angry, they'll feel disappointed in themselves, then they will restrict, or then they will purge, right? So they'll often link those together. And that's a way that you can kind of help the person understand how related those things are. So PTSD is another big one with emotion regulation. Again, a lot of people with PTSD have substance use disorders, and usually it's the emotion dysregulation that's the link. They're looking for a way to regulate those negative emotions through substances. Those people who already had emotion dysregulation difficulties are the ones who are more likely to get PTSD, right? There are traumas that can happen in a community, something like 9/11, an environmental trauma, but not everybody. In fact, most people exposed to a trauma do not develop PTSD. But a lot of times those who did had some underlying emotional trauma, and then this flips them over the edge into PTSD. So it's really important to remember that, because you're going to meet plenty of people who went through terrible traumas and are quite resilient. So you may want to think about how good they are at regulating their affect. And with others, they just maybe didn't have that, and this tested them too much. So again, severe PTSD in terms of emotions, they're usually poor at accepting their emotions. they lack strategies, they lack clarity on their emotions. So if you are working with someone with PTSD, I mean, we talk about this in PTSD before you go after the trauma, right? You want to make sure the person has grounding techniques, right? You never want to go into the trauma in intense detail unless you know the person is actually pretty well balanced in this way. So treating someone with PTSD, it's really important to help them understand their emotions and how to regulate them if you want to treat them successfully. So how do we help? What are some things we can do? So I'm going to bring in a few strategies from DBT just as a starting point, some of the things that we use. So just to start off, what about medication? So sometimes medication is going to be useful for affect regulation, sometimes it's not. But if you think it's going to be, make sure that this person has had a consultation with at least their family doctor and probably with a psychiatrist. If someone has what we call a comorbid condition, an anxiety disorder, a depressive disorder, their family doctor should be looking at treating them for that because that might help a lot. However, if those things are treated, then they may want to consider seeing a psychiatrist. There is some evidence for things like mood stabilizers, which we use in other conditions like bipolar disorder, as being helpful, but they have a lot of side effects. So they're not for everybody. It's not an automatic treatment. It requires sort of a careful evaluation. In terms of medication for substance abuse, that's probably something that's really underused, but can be really, really helpful. So getting them into an addictions clinic if they want to work on that aspect, it could be a really useful way to get treatment for that. Mindfulness, again, this is a strategy that's available to everybody. There's mindfulness groups. I think there's one here at the 519. There's online mindfulness. There's apps. There's books. This is a really accessible thing. This is going to build people's awareness of their emotions. They're going to learn about the physical changes that they're experiencing, especially if they're not good at identifying emotions. And it teaches them that you can sit through some emotions and you don't have to do something about it. Eventually they'll learn you don't have to act impulsively or you don't have to judge yourself. So this is actually a really amazing strategy that does require a lot of dedication on the part of the client, but is one that we can all kind of work on with them. CBT is another important thing. You know, it's going to help people identify their emotions and learn to reframe them. It's really important in CBT that people learn that the things that they think are facts, that they have to react or that something bad is definitely happening, that those are just thoughts. So again, these are strategies that you can use even if you're not a CBT practitioner. Psychodynamic therapy, you know, for the right patients, this can work really well and for a long time was the only treatment, right, until they developed things like CBT. That allows the person to build a long-term trusting relationship with their therapist and can help them kind of unlearn some of the attachment problems that they had earlier in life. It gives them a space to explore their emotions in a non-judgmental way and their thought processes. So for patients who are stable enough to tolerate it and who are capable of exploring their emotions, this can be a really important way. So now I'm going to talk about DBT. I put a picture of the Holy Grail here because I think people think of DBT as the Holy Grail. It's not, but it can work very well. It's also, I think, a Holy Grail because it's hard to get. It's not easily available everywhere. So basically, in terms of DBT, they think about all the different things that we've talked about: emotional vulnerability, the different events that serve as emotional cues, whether that's internal, a thought, or external, seeing or being somewhere, how the person interprets those cues, what do they tend to do as a response, how do they express themselves, and what are the after effects. There's those really important secondary emotions and consequences: losing friends, developing a drug addiction, and feeling shame, for example. All of these things are specifically targeted in DBT skills. Now, you guys may know the full DBT model basically involves group treatment and individual treatment, and having a therapist on a pager 24/7 to coach them on skills. That's very intensive. Most places that offer DBT, in terms of what we're doing in our urgent care, is just DBT skills. So it's just teaching the skills. It's not the more intensive form. So it may be important to know that, but even starting to learn the skills can be hugely impactful for people. So again, they really focus on emotion regulation in DBT, giving psychoeducation on emotions and how they're important. And learning to think of emotions as complex and brief, sometimes involuntary, and that they're responses to something else. They're not an inherent flaw in the person, as many patients tend to think of themselves. So there's different modules in DBT, basically sort of like learning themes, mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness. So as you can see, they speak directly to the things we've talked about to improve understanding of the person's emotions and the other person that they're going to be interacting with. They need to train the skills on a regular basis, like anything else. If the person just goes to skills class or just reads the manual and they don't practice, it doesn't mean much, because you need to train your brain, right? You need to relearn all these different patterns. So the assumption is that the more the person knows about emotions and skills, they'll be able to better regulate. So it's not just for BPD, right? In our group, anyone with any kind of emotion dysregulation problem who wants to work on it is appropriate for the group. They use this on eating disorder wards. You can use this for anxiety. Even a healthy individual will benefit from these skills, right? But it was developed for the extremes in borderline personality. So how do you start helping the client understand emotions? This is something important in DBT. Teach them that all emotions, whether painful or not painful, serve a function, right? The things we've talked about, they communicate distress. Sometimes they give you that motivation to work on something, right? Sometimes you need it, right? Like if I wasn't nervous about completing this presentation on time, I wouldn't have done it, right? I needed that anxiety to make me put in the work, right? So there's positives to them, signals to alert you to something. You have to remind the person that there's the emotions and the emotion dysregulation, and they're not an automatic pairing. You can have difficult emotions and you don't need to be dysregulated. Your brain has different ways to perceive it. And you want to teach the person that you can have emotions, but they don't need to control you. I think this is really important because a lot of patients with dysregulated emotion will say to you, I wish I didn't have emotions, or I hate myself for being so emotional. Everyone tells me I'm too sensitive. And that's not going to be very good for their self-esteem or self-confidence, right? Everyone has emotions. It's okay to be sensitive. It doesn't mean you're going to do something bad, right? So you need to teach them that you can have the emotions and then you can have different ways to react. It doesn't have to cause you harm. So this is a big part. One of the basics in DBT is the states of mind, and this is part of the mindfulness. So there's a little diagram here of how we think of it. So when we think of emotion dysregulation, we think of the person being in what we call emotion mind, which is, we call that emotions being in the driver's seat. The person feels out of control. Their emotions are 10 out of 10. And everything seems like facts. They can't just say, oh, maybe I'm overreacting right now, or maybe things aren't bad. They're like, no, definitely I need to do this right now. It's taken over. Then there's the other side, which is called reasonable or rational mind. That sounds good, but it's actually not. That's sort of the numbing dissociative state where you're kind of acting as a robot. So in between them, we want to help clients in DBT get to wise mind, which is where their sort of brain and body is engaged together and they have the room to make decisions. It doesn't mean they're going to stay there. It's sort of a process of going in and out. It's a movement towards it, but it's helping the people see that actually, even though they don't trust themselves and they think their emotions are out of control, there is a spot within them where they can at least slow down and maybe try to think about things. There is a part of them that's trying to work on this. So helping them direct them towards wise mind. If you hear of a client making a healthy decision or not overreacting to something, you can remind them that they made that decision wisely or that was helpful to them, because they may not even realize that they actually do have some strategies that they're already using. So emotion regulation is a big skill. The goals are to help the person understand their emotions, reduce their vulnerability, so stop them from being in states that become too emotional, and if they're already emotional, to turn down the suffering. So these are just, if you ever get a DBT manual, I'm just going to quickly kind of go through this. These are some of the things that we teach them. One way of distress tolerance, so that's when you're already at your extreme distress, is learning distraction. Now, distraction sometimes is a form of dysregulation. The difference between this being a useful strategy and not is if the person is doing it while accepting their emotions, right? If they're saying, oh my God, I'm so angry right now, the only way to get through this is to distract myself, then it's a useful strategy. If they're doing it by avoiding their emotions, then it's not, right? It needs to be sort of a concerted effort on their part, and they need to know it's got to be a temporary thing to help them lower down the intensity. So this is just accept. So this is basically things that the person can do to distract themselves in the moment, doing an activity, contributing to help others, comparing, which is basically just kind of trying to find what you are grateful about in your own life, trying to think an opposite emotion, do something else, even if it's opposite of what you're feeling, to see if that helps. Push away, again, not a permanent strategy, just in that moment. If you can take yourself out of what you're feeling right now just to give yourself a break, to give your body a break from going deeply into that. Thoughts, think about neutral thoughts, right? And this may remind you of a grounding technique if you've ever used with dysregulated clients. Sometimes if I have a patient who's dissociating, I'll ask them to try to tell me some of the items that are in my office, right? Because that's a different kind of thought. It takes them out of the emotion and just engages their brain on a different level. Sensation. So again, this is just using your senses. It says drinking a hot beverage or enjoying a warm bath. So again, just giving yourself a different physical experience. Another distress tolerance thing is self-soothing. This is basically self-care using the 5 senses. So again, engaging parts of the body in a positive way, right? And it could be as simple as we have, if you've ever been to a DBT skills group, we have a basket of different things to distract and distress. And some of those things are like a rock that the person can kind of hold on to, or a stuffed animal that they can squeeze. We have a little bottle of lotion that the person can smell. There's lots of different things. We have a coloring book so they can color in different colors. These are all different ways to kind of use your senses to calm yourself. Turn that intense part of your brain off for a moment. There's improving the moment. Basically, this is just positive imagery, right? So these are all very simple strategies, but the person may really need to learn them over and over. So kind of visualizing something relaxing, figuring out what you can do in that situation, praying, whether the person's religious or not, just asking themselves for strength. Relaxation, is a mindfulness, one thing in the moment, so just to try to figure out one thing at once. Again, these are all kind of similar strategies. Vacation, giving yourself a mental break. E is encouragement, giving yourself positive reinforcement that the person's probably lacking, learning to tell themselves, I'm in a difficult situation right now and I need to get through it. There's pros and cons. This is a strategy I would recommend people do before they're in distress because they're not going to be able to think this way. This is also something people do in CBT, is write down a list of pros and cons and keep it in their wallet or on their phone. If there's a specific dysregulation strategy like drinking or getting angry that somebody wants to change, get them to go through the pros and cons of doing it and not doing it, because you need to acknowledge to the person the strategy does have a function. Maybe it does reduce your distress in that moment. It's really important that they understand that they're having a reasonable motivation for it, right? But you also want to go through what are the long-term consequences, and there's going to be cons to doing a positive behavior because it may not feel very good or it may be really hard to do. But as long as you can get them thinking about the long-term pros and the long-term cons, it'll cement the strategy a little bit more for them. So this is a good one to prepare when someone's in a calm moment. There's tip skills. These are really good ones, I think, to have an intense emotional crisis. This is when emotions are at 10 out of 10. These are things that actually are basically meant to engage the nervous system in a different way. T is temperature. So we keep an ice pack on hand in DBT skills groups because the person can grab onto that. That just sends a shock through the body without hurting yourself. You can recommend that people put their head in a sink of ice cold water, run into a hot shower, even running your hand under a sink of very cold water. It'll just give your body something else to do for a moment, and it'll at least shut off, certain parts of that activation. So it can be really effective. Intense exercise. Again, we're thinking like 30 seconds, just like the person can do jumping jacks or run in place. Get rid of that adrenaline that they're feeling is basically, when we talked about that adrenaline surge, this is a way to work it out, use that muscle energy without kind of letting it burn off in an emotional way. And then there's P, progressive muscle relaxation. There's lots of tracks for this on YouTube. This is a form of basically kind of physical meditation where you kind of squeeze tightly it's called progressive because you go all the way down your body, every muscle group in your body, squeeze it intensely, then relax it. And eventually your whole body has been relaxed. So again, you've used your body in a different way. Another emotion, again, I'm just going through DBT skills. Even the most simple groups usually take 20 weeks. So I'm just going through some of the strategies you might see just so you know the context. Please mastery is an emotion regulation skill to basically stop the person from embarking on an emotional roller coaster. What it means is kind of physically taking care of yourself so that you're not already in a dysregulated state and too sensitive. So treating physical illness, sometimes this means the person needs to make sure they're taking their medication, because if they're on and off with their medication, withdrawing all the time, or it's not working, that's not going to be very good for them. If they have a physical illness, some people, especially those who grew up with neglect, are not good at taking care of themselves. They need to know they're important enough to go to the doctor and get help. And if you're feeling okay, you're more likely to handle your emotions. Balanced eating, again, you think about this with these eating disorders. People may have binge eating, or they may skip meals when they're out of control. That's gonna, not be very good for their blood sugar. And, think of how unpleasant people get when they've skipped a meal, right? So just teaching the person eat 3 meals a day to take care of yourself can be a big deal. Avoid mood altering drugs, right? Even if the person has the urge to use to change what's going on, just tell them not to. Balance sleep. This is a big one. A lot of people have sleep dysregulation. Sleep hygiene principles are something that you can look up and help the person reinforce, basically about going to bed at regular times, not using screens before bed, not spending too much time in bed if they can't sleep, and getting out of bed at the same time every day, so they're not misusing their energy that way. Exercise is a light antidepressant, so especially if someone needs that boost, it's going to really help them. And achieve mastery. So mastery basically means making sure the person dedicates themselves to tasks that are not necessarily fun, but helps them feel better about themselves. It might be cleaning up their house, it might be going to work. It's just something that they need to do every day to sort of build that sense that they are capable of getting something done. So just for the last little part, I adapted this. If anyone, there's a doctor at CAMH who's kind of the big DBT person, is Carmen Wiebe. She gave us a presentation when we were residents about how to deal in the ER with using DBT skills. So I've adapted this a little bit about how to take care of ourselves when we're dealing with acutely distressed clients. So again, in that part that I just did the DBT skills, there's a lot more. Those are just some of the basic emotion regulation ones that I think are fairly easy to impart with patients. So use of time. People who are emotionally dysregulated can be very time consuming for us to deal with, right? We want to calm them down. It might take forever. Make sure it's productive. If you're spending extra time with a client, you should be actively listening and validating what's valid, not validating negative strategies, but validating the fact that they're asking for help and that they're talking to you right now is good. Provide them with skills. Talk to them about the different things they can do. Remind them that they have skills. Remind them of other situations where they've been able to get through it. Problem solve the most active issue. Whatever's going on right now, focus intensely on that. If you're spending extra time focusing on early life events, that might be relevant in a different setting, but it's not relevant today. You're not going to solve it today. If you're only being supportive and you're not giving them skills, it's probably not the best use of time. If you feel that you're just listening while they're yelling out abuse at you or venting, that's not good for you. It's not good for them. You may need to end the interaction then, right? So making sure that's productive on both sides. Learning the skills in the relevant context, right? Basically, this means don't let the person avoid. They're not going to learn anything. So you can remind them their urge to do things like to self-harm, to use substance, to be admitted to the hospital. Those things are understandable. You understand why they don't want to deal with what they're dealing with, but maybe it's not going to be helpful for them right now, right? You want to remind them that they need to learn to tolerate the emotion, and maybe they have a problem that they need to solve, and you can help them with that. So again, remind them about whether the avoidance behaviors are helpful or not in terms of their goals. Remembering that long-term problems need long-term solutions. So some of this is just around hospitalization. If you're worried about a patient, bring them, if you think they're at risk, if you think they're going to kill themselves and they need to be hospitalized, bring them in, right? But sometimes people have suicidal urges and doesn't bring them to hospital isn't going to solve anything, right? Maybe they have ways that they could deal with that you could remind them. So sometimes that reduces the risk, bring them into hospital, but sometimes it doesn't because it doesn't teach them that they might be able to deal with this in a different way. So if they have an outpatient therapist, if that isn't you, try to refer them back, see if they can see that person, help them, but still help them problem solve what's going on today. If things aren't working out, don't discourage them and say you need a new therapist, right? Don't do that unless you know that things are really not working out, right? Again, just be there for them in that moment to problem solve and to remind them of skills. Power strugglers are unhelpful, right? Again, this is about taking care of us. We need to take care of ourselves, and it's not good for the patient, for the client either. A power struggle is only going to dysregulate them more. They're going to start getting into other things, right? Reminders of their childhood abuse in the past, or feeling another kind of level of distress about what's going on, and we're going to end up feeling agitated and angry or resentful. So make sure you listen and validate. If you think there's a power struggle going on, if they're asking you to do things that you're not comfortable doing, even if that's taking up extra time, whatever's going on, you have to be clear and direct with what you can and can't do. If you think there's a power struggle, say, I don't want to get into a power struggle. It's okay to say that to the person. Make sure you focus on, their strength, the fact that they did come in to ask you for help, things like that. If you find you're in a power struggle, if you're feeling like you're withholding or denying, or they're asking you for things you can't give, make sure you're calm, take a moment to breathe yourself, tell the patient you're not comfortable with what's going on, and try to find something valid about what you're going through and what they're going through, right? It could be as simple as saying, clearly you're asking for help right now. Clearly you're in distress right now, right? Reduce your own anxiety, right? Reminding you that you can teach the patient in the moment about skills and not avoiding, but that doesn't mean they're going to do it, right? We can control the person, and sometimes we're helpless, right? Sometimes we don't, someone's going through something horrible and we can't stop it, right? But it's okay to remind yourself that you're still doing your best. You've tried to orient them towards skills. So observe your limits, right? If you think something risky is going on, if you think the patient's going to harm themselves or go use, some people are more comfortable with it than others, depending on the type of clients you work with, depending on the kind of training you have, your own personal life experiences. That's okay. Your colleague might be able to handle something that you can't. Just remind yourself that you're doing your best in that moment. Now, you have to be able to tolerate some risk. You got to give the patient some faith that they can work on themselves. But if you don't know the patient well, get help, right? Turn to somebody else. If you need to bring them in a hospital, bring them in. But make sure that if you know the patient well, is this their usual pattern, right? Do they usually escalate to this point and then calm down without hurting themselves, or is this a dangerous situation? And also, sometimes we're going to disappoint people, right? Sometimes we cannot solve their problem, or sometimes our attempts to help them get skills are not going to work for them in that moment. You don't have to give up. You just need to tolerate the fact this person's going through a difficult situation and I don't have an easy answer, or the things that I wanted to work did not work. And remind yourself that it's okay if you said no. It's okay if you can't do something for them. It's okay if you ended the session because you don't want to get into a power struggle that isn't going to be healthy for them, right? The point isn't for you to feel trampled on, right? The point is, the whole thing with skills is that it can be really empowering for clinicians because you're helping remind somebody something that they can do, right? It's not about us doing something for them. It's about us directing them to their own empowerment. So some books I think that are helpful. So just to finish up, I think this is a great book. It's really so popular that I've actually seen it at Costco, which I think goes to show how much DBT skills are needed everywhere. But even if you don't have access to DBT and you're working with a patient regularly, go through this book with them. It simply goes through some of the skills we've talked about today. It is not a substitute for DBT. It's just a book, but it can help teach somebody some strategies and give them the language, right? Help them work on things. Yeah, it's McKay, MCKAY. If you search for McKay DBT on Amazon or anything, and it's only $20, so it's very accessible to patients, I think, from all income levels, which I think is great. For family members, if you're working with a family member for dealing with emotional dysregulation, this is a popular book, Stop Walking on Eggshells, how they can help regulate themselves, right? Because you don't want the whole family to be getting into problems. There's lots of other books. These are just a couple that I have found useful. People might have their own recommendations, and I'm happy to have you share them. Resources in Toronto. So as I've talked about, DBT in particular, resources are few. There's private services, which I mentioned at the end, if the person has any funding for that, whether through their work or their own personal finances. There are DBT clinics that you can search online. That's going to be the fastest way to get it. Most of the people we work with cannot afford that. It is not cheap. For people who are young, there is a clinic called Stella's Place. They have support for all different kinds of mental health concerns, but I think they do run DBT groups a couple times a year. People can self-refer. There's a group called, or a sort of program called Sash Spare. It's named after a young woman who I think died after a struggle with borderline personality disorder. They provide education and family skills groups. You can look them up online, so if people need support for their family members. CAMH is sort of the biggest place to get DBT. Sometimes their wait list is closed, sometimes it's open, sometimes they're doing studies and they have more opportunity. You need to check the website. The patient needs to be self-motivated to call and get on the waiting list because sometimes it's open one day a month. They also have family support groups that I think are a little bit more open. For other sorts of ongoing problems, anxiety disorders and depression, there's support groups at the Mood Disorders Association of Ontario. There's, for people with addictions problems, you want to make sure they're dealing with that. Sort of one general way to approach that, they can self-refer to Mars, which is a citywide sort of service that will connect them with addiction supports. Again, people may have lots of others. These are just a few that I thought of. There is a clinic called Davenport Perth that has a DBT group that patients may be able to, I can't remember whether they need to self-refer or go through their family doctor. But again, those kinds of things are few and far between, unfortunately. As I said, mindfulness is pretty freely available in a lot of places. So it doesn't need to be DBT. That's just one approach. There's lots of other things that can help someone. Okay, the end. So I'm happy to take questions from anybody. Oh, it's 1:30, sorry.